So I'm really excited to be with you tonight. I don't know how many of you have been in offices and done lots of clinic, but understanding a hearing test is a really important skill to have, and hopefully you can build upon this. The goals tonight in the next 20 minutes or so are to understand the components of an audiogram, to be able to interpret an audiogram, and to know the types of hearing tests available. I'm going to spend about 15 or 20 minutes just explaining how to read, maybe it's even 15 minutes on an audiogram, how to read an audiogram, and then we're just going to look at audiograms, and I'm going to have you read them because you're going to gain all that skill in the next 15 minutes. Okay, good. Okay. So I was just telling you the goals. You got that. You're gonna be able to interpret audiograms tonight. Going over the basic anatomy, the auricle, the ear canal. And what you really want to know is that I've always thought the shape of the ear, the auricle is such a weirdly shaped, organ. It's a really funny shape, but the ear canal and the auricle are really set up to enhance the acoustics of sound. And the eardrum is picking up a certain amount of that amplified sound. And then there's this series of levers, the bones, that are going to transmit, and it's going to be multiplied, the sound, so that the cochlea receives this fantastic information, which the brain is then going to interpret. Okay. Oh my God. Oh my God. Okay, so here's an audiogram on the right side of your screen. And we're going to look at all the components of this and kind of break it down so you can understand it. Now, I have my cursor here, right? Can you see my cursor or not really? No.
Yes. Yeah, we see it.
Okay. Thanks. All right. So air conduction. Air conduction is the sound that you hear from your ear. And that's going to be represented on this audiogram by, in the right ear, and right is round, are these red circles. And the X is the left ear. And that's going to be the air conduction for the left ear. And that's what you're really hearing. That's what the patient and the person really, the level of hearing they're at. Here you're going to see kind of like a, little leftward mark here. And that's going to be the bone conduction. And bone conduction is going to be what the best hearing that the nerve can do. So in the perfect world, the bone conduction and the air conduction are the same. And in this case, this normal audiogram, that's what we're seeing. Now, normal hearing is going to be above 25, and I'm going to draw a line right here with my cursor at 25. So you can see that for all the frequencies, 250, 500, 1000, 2000, 4000, all those frequencies from low to mid to high, we're going to, we're in the normal range above 25 decibels. Okay, and as we go down here, this is where we're going to go. We have normal hearing, mild hearing loss, moderate hearing to severe hearing loss to profound. Down here in the legend, if you ever get confused, there's usually a key, and you can look at the key and it'll help you to remind you, what these little marks mean. Now, word discrimination is, we'll start with thresholds over here. On this, we're going to look at this block right here. And this threshold is going to be an average of these these sounds in this area for each ear. So you're going to have an average of these pure tones in the right ear and the left ear. Now, pure tones are just these pure sounds, these frequencies. And that's not really what sound is. Sound is a real mixture, colorful mixture of sound. So, but we want to find out what's the quietest sound at these frequencies that people can hear. And then we average them from 500 to 4,000, and we get an average here for the right ear and the left ear. Now down here is something called percent recognition or word discrimination. And word discrimination is your ability to really understand the words that you are hearing. And they're going to give you the phonetically balanced words, which have certain sounds in them that have a frequency in the English language, in each language. We're going to go 40 decibels above your threshold. Hold on a second. My dog is chewing a bone really loud. Okay. There. All right. Sorry. And you're gonna go 40 decibels above. So it should be really, really easy to understand for people. And you're going to give them these phonetically balanced words. And this is a percentage of the words they get right. Sometimes as people age or for other reasons, people will lose their ability to understand speech. So even when you give it to them loud enough, the sounds, it's all very garbled. It sounds like blah, 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 and they really have a lot of trouble. The next test that's going to be visible on the audiogram is the Tympanogram. And I'm going to go into that a little bit more in another slide. And that's going to give us an indirect measure of the middle ear pressure. If you've ever been in an airplane and you felt really plugged up, you might have felt like you might have had negative pressure. And on the tympanogram, we're going to look at the mobility of the eardrum at different pressures. From -400 to +200, a sealed probe is placed in the ear canal, and we're going to see where that eardrum moves best. And where it moves best is going to tell us kind of where what's happening in the middle ear. Down here, there's the acoustic reflexes. And acoustic reflexes occur when the muscles of the chorda tympani and the stapedial muscle, when they're exposed to very loud noise, they will tighten the whole system in order to protect the ear. And that will happen around 70 or 90 decibels. I used to have some parrots in my kitchen, and every time the phone rang, the parrots went crazy, and my stapedial reflexes were clicking all over the place. It's super annoying. The other thing that most audiologists will do is they'll have some history down here, and it'll usually be way more extensive than this. And they'll tell you some history about the patient, and they'll also tell you about an interpretation of this whole thing. So you might, if you don't, for the doctors who don't know, for the primary care doctors who have ordered the hearing test, they don't have to be able to know how to read all this, and they really can't. But tonight, you're going to know how to do this. The other thing that's here underneath this, the audiogram, is the reliability. And the reliability will be usually good, fair, or poor. And reliability is important. Now, some people might not be as reliable because they just can't understand how to follow the instructions for the test. Some people might be faking a test. And so a really good audiologist, you really can't fake with a good audiologist. You know, they have little tricks up their sleeve, and we're going to look at some of those tricks tonight too. Oh my gosh. Why does my next slide not work? Okay. Okay, so air conduction. This is an example of somebody having an air conduction test. She's sitting here with headphones on because that's where the sound's going into her ear, and she's going to click, and she's going to provide, the audiologist here is going to provide her with those sounds, with those per tone frequencies, and when she hears them and she's going to go quieter and quieter, she's going to click, and she's going to mark down at each frequency where the quietest sound she can respond to is. This is bone conduction. Again, bone conduction is going right to the cochlea, and we're going to get our best hearing, the best the nerve can do through bone conduction. And when there's a difference between the best our ear can do, the bone conduction and the air conduction, we call that an air-bone gap. And so you can see that there can be problems. I mean, you can have earwax, so your air conduction can be worse than your bone conduction. You could have a hole in your eardrum. You could have fluid in the middle ear. And the air bone gap will look like this. The bone levels are going to be up here, This is the right, red, and the left, and then the right hearing is down here in the left hearing. That's your air bone gap. And you would say that there's each one of these blocks is 10 decibels, and you'd say, oh, there's in the left ear there's a 10, 20, 30 decibel air bone gap at 1K. Or you could kind of say, well, there's an air bone gap from 30 to 50. You know, you can interpret it in different ways, but at least you understand it. Word discrimination. I talked about these phonetically balanced words, and these are some of the words. And the audiologist will hide her lips, and then she'll say these words, and then the patient will repeat them back. Tympanograms. Again, we're going to put a sealed probe, and we're going to apply -400 pressure. So you can imagine that -400 or that +200, the eardrum's not going to move so well with that kind of pressure going on in the ear canal. But right when we get to, if the eustachian tube is working, this middle ear space will be at 0 atmospheres. And so when the sound hits the eardrum and we check the mobility, the eardrum's going to move its best at 0 atmospheres, and that's going to give us a good type A tympanogram. Now there are there are 5, but we'll talk about the 3 main types here of tympanograms. So if your eustachian tube is equalizing and atmospheric pressure is at the middle ear and the ear canal, your eardrum will move best. There's also a height to this tympanogram. That's the compliance, the way that the eardrum moves. The type B tympanogram here is flat. Now, flat tympanogram can occur for a number of reasons, and that can be that it's just not moving, and it could be fluid in the middle ear. It could be a hole, and there are ways to tell whether there's fluid or a hole, and we'll go in. I gotta go back. There's one more thing on the tympanogram that I didn't show you on the audiogram, and that's physical volume of the ear canal. The usual ear canal volume is about 1 cc, and if it's really big, that means that there's an opening there. It could be a tympanotomy tube or perforation. If it's really small, like 0.3, there might be earwax or some canal stenosis, okay? So that's just another thing to keep in mind that's on here that I forgot. And also, she did an ear check, and there wasn't any cerumen in the ear canal, so. All right, let's go back. I'm sorry. All right, so here are the tympanograms. Again, this is type A, type B, and type C, which is there's negative pressure. So where the eardrum move the best, this means that they're congested. You know, there's a lot of congestion in the middle ear. And then there's the compliance. Here's, if it's a really floppy eardrum, it's going to be way up here. And if it's a stiff eardrum, it's going to be here. And this is more of a normal compliance to the eardrum. These can cause, you know, the way the compliance is, both high and low, AS and AD, can really affect, can add a conductive component to hearing loss. And you might see a little air bone gap. So here again is the AS, and here's AD. When it's open all the way like this, there might even be an ossicular discontinuity, which makes the eardrum really floppy and could add to a conductive loss. So here's just some pictures. So we would expect to see a really large canal volume on the audiogram when there's a tube. We won't see that, but we will see a type B tympanogram, a flat tympanogram with all 3 of these pictures. And here you see a perforation. So let's move on to newborn hearing screening. There are 2 ways in which most newborns are screened. In about the year 2000, something really fantastic happened, and there was the institution of universal newborn hearing screening tests. This was life-altering for children who were born with hearing loss and sometimes not identified until age 2, and sometimes school age for the mild to moderate hearing loss children. All newborns, at least at places that have at least 400 births, all newborns are required to be screened before they go home. there are different types of people who screen. Often it's a nurse. Sometimes there's a particular team of people at the hospital who do it. Reliability, well, babies are done their best when they're sleeping. 2 to 10% of these tests can be, you know, are going to be abnormal, but they're not abnormal. They need to be repeated, and we need further testing. It's a challenge to sometimes get all these kids who failed the test of the newborn screen and to make the pediatricians aware and to make sure that they get further testing to ensure that they are normally hearing. Even unilateral hearing loss can have an impact, but hearing loss in children will have, that goes undiagnosed, will have terrible effects on their educational and other development. So how do we test kids? So beside the ABR, which is a test in which the children don't, or otoacoustic emission testing, where they don't really participate in it, at some point you begin to test children. And so we test kids as young as 10 to 12 months with sound field testing. And as they get a little older, around age 2, we do conditional play audiometry. And sound field testing, I'll show you a little video, is basically having a kid on a parent's lap and the speakers are going, and we're gonna condition them to look at a toy, and then when they hear the sound, they'll look up. And when they look up, we kind of know that they're hearing the sound, and we get a basic idea in the sound field of hearing in at least one ear because we don't have headphones on. And in conditioned play audiometry, we're hopefully getting the headphones on, and we're giving the kids like a block or a toy, and we'll put the block up and we'll say, as soon as you hear it, you know, throw the block in the bucket or do something, and they can get the kids to, they can play along with this and find a best hearing level. So I think I have a little video I'm going to try to play. Let's see if this YouTube video works. This is another first for me. Can you see this? Is it showing up? Okay, okay, good.
We have 2 ways to test children in our sound booth. We can start doing that at about 12 months of age with a technique that's known as VRA, or visual reinforcement audiometry. In that case, we have the child sit on the parent's lap, we play sound through speakers, and then reinforce them to look for that sound by playing a little animal. They get involved in looking for the animal, and so they listen for very soft sounds and let us know what they can hear. As children get a little bit older, we use a technique called conditioned play audiometry, and that involves playing with blocks and listening for a sound, and when they hear the sound, they throw the block into the bucket. By making it like a game, they will listen for soft sounds and let us know what they're able to hear.
Okay. All right, let's see if we can go back to my slides. All right. Uh-oh.
We have 2.
All right, now this is the tricky part. How do I get back to my slides?
To test children in.
Let me click out of this, and click to, oh, what's this? Oh, yay, I did it, okay. All right. Let's go on to the next slide. All right, so another way that we test kids' hearing when we really have concerns and the kids are, you know, we have to have the kids asleep for the for the ABRs. And when we do them awake in some children, but sometimes they get a little older and they just won't go to sleep. We sometimes we'll put them to sleep under anesthesia and do an ABR. And another name for an ABR is an auditory evoked potential test. And what we're doing is we're going to put clicks, broadband sound usually, and we're going to put clicks in the ear, and we're going to look at the brain waves, and we're going to look at different sound levels, like at 80 decibels, 70 decibels, 60 decibels, and we're going to look at like the waves. And we're going to see, you can see here wave 5, and they're mostly looking, I think, at 1, 3, and 5. And as you go down, you're starting to see a flattening of wave 5 as the sound gets quieter. And that's where the audiologist is going to determine the hearing levels are. So the next, now that you're all experts in how to read a hearing test, and I know you are, because if I can do it, you can do it. We're going to look at some audiograms. Let me get to make this bigger. Can you see it as a little bigger? Is that good? Okay. So what I want to do is, this one's kind of hard. Let's go to this. We'll go back. We'll work backwards. Okay. Uh-oh. Now we'll start out here. Okay. So the one thing I didn't show you, I think it's the, oh, okay, that's the, oh, I'm really sorry. Sorry, guys. Okay. So what I'd like to do is just have you guys read some audiograms and we can go through it. I have to look at your names though. It's Amir. Amir, if you could help, if we look at this audiogram, how would you describe this audiogram? Remember, 25 decibels is normal. Can you?
So it looks like this patient has mild hearing loss up until about 1,000 hertz, and then it gradually decreases to pretty significant hearing loss for the rest of the audiogram, but there seems to be another uptick at around 6,000 hertz as well, where it improves slightly, but there's no bone air gap between the two, and it looks like the left and right ear are about the same.
You know, the audiologist made these up for me, and she didn't actually put the bone in.
Or no, there's no bone, right? It's just the left and the right that are the same.
I just noticed that, but you're right. Oh, let me go back. Oh, I'm like a disaster here. Hold on. With this, oh, man. Okay. So, right. So, but basically you're right. There's a mild loss with then a sloping loss from mild to profound. And this is in the profound range here. Now, if we go over here, the averages are there, right, for the right and left ear. And percent recognition was only 16% and 20%. So that's pretty poor discrimination. It's going to be really difficult, even with amplification, to understand speech. What can you say about the tympanograms?
The tympanograms look fairly normal. Looks like type A on both the right and the left. And the height is normal as well, which I don't remember the letter right now.
Right. It looks good. All right. Yeah. That's a pretty normal looking. They draw those in after they do the actual, they get a little graft and they draw those in, but she drew it in to mean that it was really normal looking. And the physical volume, I guess for this patient, they must have a big ear canal because they have type A tympanograms. There was no concern. Patients with this amount of hearing loss may not have acoustic reflexes. It's just too much loss to even have, so they may have absent acoustic reflexes. All right, let's go on to the next one. All right. I am not seeing, let me see if I can. frustrating. Michelle, can you do me a favor?
Yeah.
Can you pick somebody to read this? I just can't bring up, for some reason, I'm not bringing up the group.
Oh,
Oh, there it
Does,
is.
does anyone want to volunteer to try and read this one?
I'll go.
Okay.
This is Shadi. Hi.
Hi.
It looks like they have definitely an air bone gap, and then loss that's greater on the I think I don't see the color
Oh,
color coding.
the right one, the right is round.
Okay.
And so that's how I remember. Right is round, and it's also red. So it's got
Okay.
3 R's. That's the easy way to remember it. So here,
Okay. So they don't have an air bone conduction. It's the left ear they have hearing loss, and right ear is normal.
correct.
Cool. And then the tympanogram looks good, I think.
Yes.
And then I can't totally see the numbers.
It's 100% in the right and 44% in the left.
Okay, yeah, which matches with the pure tones.
Right. Good. This was, she wrote this up as a sudden hearing loss, that somebody presented with all of a sudden, they complained of just a very fast occurrence of unilateral hearing loss. And that can be, that's kind of an otologic emergency. And pretty much the standard of care right now is you can do trans-tympanic steroid injections and see if you can get them in the first few weeks of this occurrence. But you can see that the discrimination is so different than the on the left and the right at 44% compared to 100. Now, when I read the right, I would say that there's normal hearing in the right ear with a mild high frequency loss. And in the left ear, I would say there's a severe upsloping, then downsloping sensory neural loss from severe to moderate to severe. And so you can kind of see what's going on with this diagram. Let's go on to the next one. All right, who's next? Oh, wait, we did that one. Okay. All right.
Who would like to try this one? This one's different. This is not a sensory. Oh, I shouldn't tell you that.
It's
not the same as the last one. Let's put it that way.
I can try this one. I'm Aviv.
Great.
So looking at the right ear, the round, it looks like there is normal hearing throughout, no hearing loss. But looking at the left ear, there seems to be an air bone gap. So the bone conduction is normal, but the other conduction, you're in the mild to moderate range.
Nice, nice. Now, so you can see that the averages, the pure tone averages for the right ear are 15, which is normal because normal is 0 to 25. But the average air conduction average for the left ear, although is 40. So you can see the effect that there's something that air bone gap is having on their hearing. But they have really good speech discrimination, right? At 100% and 96%. Now remember, this number 55 and 80 represents just bringing 40, that they presented these, the words at 55 decibels and 80 decibels. Now, what about these tympanograms? What type are they?
This could be, so I'm going to go with B.
Yeah, it says B.
The significance of which I can't quite remember.
It's something's making it so that you can't get sound to move the eardrum. So either it means there's something wrong in the middle ear where there's fluid or something like that, or there's a tympanotomy tube or a hole in the eardrum. Now, we can figure that out. Is it a hole or is it fluid? By looking at the physical volume, the ear canal volume. The ear canal volume is going to be a measure of either just the ear canal from the probe to the eardrum, or it's going to be, if there's a hole or a tube, it's going to give you the ear canal plus the middle ear or beyond. So remember, it's about, normal is about 1.2, 2 ml, and this is milliliters. But look what's going on the right.
Right, it's much larger than 1. It's suggestive that there is a hole there causing a larger volume.
Right, right. And on this, she writes that there's a PE tube. So the PE tube is allowing the canal volume to be 5.2. But what's on the left? Look, we have a conductive hearing loss and we have a normal canal volume. So one of the problems could be what? What could be causing this air-bone gap?
Like an effusion.
Yes, excellent. All right, so normal hearing with PE tube. So the PE tube is working. So putting it, so the point of this is ear tubes are good, right? They're really good. And fluid is bad. So if you're a kid in school and both your ears have fluid and you're hearing at 40 decibels and you're in the back of a classroom, you might have some trouble. But if you have your ear tubes and you're in the back of the classroom, you're good. So ear tubes are good. All right. All right, this time.
I want to take a shot.
All right, let's do it.
All right. So it looks like, looking at the right side, we have normal hearing until higher frequency ranges, until we get to some mild sensorineural hearing loss. And then there's an air-bone gap at low frequencies on the left side,
Yeah.
as high as into some profound hearing loss at lower frequencies, and narrowing as we get to higher frequencies. On the right, there's a type A tympanogram indicating a normal TM, and on B, there's a flat tympanogram. So on the left, there's a large physical volume indicating that there may be a perforation,
Right.
and it looks like the difference in the air-bone gap is about 30. Maybe it's a little bit higher. It's hard to see on my phone. So a perforation could be attributed for the entire air-bone gap.
Right. Now, I have more, but I think I've gone over, right, Michelle? Have I gone way over?
The time doesn't matter. If it's up to, you can finish. If people don't want to stay, they know they can just go.
Okay, okay. So I'll just run through these so you can kind of see a few more, just so that for time sensitivity. Here you can see the right and left ear. There's just a severe sloping sensory neural hearing loss with fair to good discrimination bilaterally, good reliability, hearing levels 55 and 45. This is a patient who might have had a history of noise exposure. He's 66 years old and was exposed to high levels of noise. Tympanograms are good. What we want to do for this patient is make sure they get hearing aids, and they should do really well, because we're going to bring all these levels, and what the hearing aids are going to do is they're going to give them frequencies. They're going to give them what they need at at the different frequencies, as opposed to just one amplifier amplifying everything. I wanted to show you what an audiogram in the sound field might look like. There'll just be a bunch of S's, and you'll get just a basic idea of where the kids are hearing. And because remember, they're using both their ears, we're not getting ear-specific information. So that's what this looks like. And this was conditioned play in the sound field. And it was done with picture cards. But you can see they have some middle ear dysfunction, and they have a little negative pressure. It's not fluid maybe, or there might be a little bit of fluid. It depends. Fluid can develop, you know, after -200, you might have a little fluid. You have to look in the ear to see what's going on there. This is a real, this is a post-fitting of a cochlear implant. This isn't on this old form, but it'll say CI. And a CI test is done in the sound field as well, so that they are using their cochlear implant. This might have been where they were hearing in the right ear. This is a right cochlear implant, and this is where their cochlear implant corrects them so that they're able to hear at 15 decibels, even though they're hearing. And these arrows mean that it's really non-detectable hearing. It's even probably worse than that. But with a cochlear implant, which is another really good thing, and an amazing thing, they can hear. This is a patient who has poor reliability. And I mentioned this before, that they wouldn't respond to any words in the word discrimination. Their sounds were, you know, they wouldn't respond to any sounds. They really wanted to maximally fake this. And what the audiologists sometimes will do is when they instruct them, they have a microphone, and they can make the microphone at different levels of loudness. And people will say, they'll take instructions or talk to them at those quieter levels, and they'll know, you know. And this patient was so resistant to giving the audiologist. She used otoacoustic emission testing, what we use in a newborn. And they had normal reflexes. They had normal otoacoustic emission testing. They were just faking it. So what I tell my patients is, do your best on these tests because they're gonna know. And it kind of scares them into really making an effort on their hearing tests when there's a secondary gain of some sort. And that's it. You guys are great. Did a great job.